Welcome to another RegiMed video, and in this video we'll be talking about the guidance that was produced by the National Institute for Health and Care Excellence, or NICE guidelines, that were produced right at the start of the COVID pandemic in the UK and was used as a framework for assessing patients with critical care. It's recently been updated, and there's a variety of different aspects to the document. It talks about admission into hospital, admissions into critical care, starting, reviewing and stopping critical care management of patients, and about the joint clinical decision making that's involved in managing these patients. Now, I'm not going to go through all of those parts, and it's really worth going on the NICE website and checking the document for yourself, and I'll leave a link in the description below. However, we'll talk a little bit about the major changes that has happened with this and the changes in our practice that we should be observing. I'll also then segue a little bit into extracorporeal membrane oxygenation, or ECMO support, and the guidance that has been out there in the past, and debating some of the potential problems with using those guidelines in managing these patients with COVID-19. So the first thing to say is that at the point of admission into hospital, the big change is that we should be assessing these patients for frailty by using what NICE suggests is the Clinical Frailty Score. There are various other ones available, but essentially it's a way of looking at pre-morbid state and physiological reserve of patients. This is all the stuff that we as intensivists were doing day in, day out when assessing patients for suitability to intensive care. Now, with this, what we're trying to do is assess whether patients would survive intensive care and whether we'd be able to provide them with a good quality of life after intensive care. They do make a point of saying that it shouldn't be used for patients who are young. They don't exactly define who that is, but certainly those patients under the age of 60 you should be careful about using, and certainly those under the age of 30. We'd definitely be careful using this, and it's not really designed for those patients. It's not really designed for patients with long-term disabilities like cerebral palsy, those with learning difficulties or autism, where they could be skewed to having worse scores, but actually physiologically not be too bad. Now, the fundamental change that has happened with the NICE guidelines is that we should be recording frailty assessments of every patient in their notes at the time of admission. I think this is really important, and it's really starting to shift the notions of what intensive care is and who's suitable for it. I think we can all as intensivists think back to patients that have been referred to us who probably were not appropriate for intensive care, who we hadn't empowered the base medical and surgical teams to have those thoughts about whether patients should have intensive care. And I think every one of us who's been in intensive care for long enough can think of patients who we've brought through intensive care, but given them a quality of life that they, as the patients, weren't happy with. And speaking to those patients, they would readily say to you, if they'd known this is what their quality of life would be like, they probably wouldn't have wanted intensive care in the first place. And certainly by using frailty scores, assessing these things early and starting these conversations early, we're able to better serve our patients and give them the treatment that they want and give them the quality of life they want after their stay in intensive care or in hospital. So the Clinical Frailty Score looks at a variety of different things. And basically, it's exactly what we would do at the bedside, trying to assess their pre-morbid state. Now, the Clinical Frailty Score says that anyone with a frailty score of 5 or above, you need to think very carefully about do not attempt resuscitation and about their suitability for intensive care. Now, 5, I think we've all, as intensive care doctors, looked after these patients who are mildly frail, but we're able to get them through short-lived acute critical unwellness fairly well. So I think 5 is a little conservative. 6, definitely, I think this is the patients that we really need to think about whether we're able to provide them with a good quality of life after intensive care, or even in fact whether they would survive the insult of intensive care in the first place. So 5 is what the guidelines say, certainly above 6. for just general patients outside of a pandemic, we really do need to think about. They do make some points about patients with dementia. For me, personally, I find patients with dementia very difficult to decide what the suitability is for intensive care, and I think a really robust conversation with the patient, if they're able to, and the family is really important, because the expectations and the conversations around healthcare in these patients can be quite complex, and really we need to work together with the family and the patient to see what's right for them. Now, one thing that they talk a lot about in this document is discussion with the patient and the family, and I think that is vital. It's key to all of this. COVID in some ways is quite a nice disease in the sense that you usually have a period of time that the patient is lucid, they're able to discuss things, and they're able to have capacity to make those decisions, despite actually physiologically not being too well. And I think we should use this opportunity early to discuss these 4 fundamental things. And the 4 things are: how will critical care treatments help the patient, not just in the short term, but the long term? Will they survive? Will they be able to get back to their baseline level of function? Now, unfortunately, with COVID-19, we're so early on in the disease process that the genuine answers we just don't know. They do seem to be recovering, and young people, certainly in China and in Italy, are getting off quite advanced levels of organ support and being able to get home. Now, we don't know what the long-term outcomes for these patients are going to be, but certainly there seems to be recovery in a similar way to other viral pneumonitis, so I think it's worth considering it in the same sense. Now, I think this is the really core and key point, is the second one. Could critical care treatments offer quality of life that is acceptable to the person? Now, that is so person-specific, family-specific, that you really do need to have that discussion with the patient and their family in tow. Now, the slight confounding factor here is that some people say, oh God, I could never live in a nursing home, but actually then those who do end up in a nursing home say, oh, this is really not as bad as I thought. So you've got to have that conversation, allow people to think about it, and not to make rash decisions based purely upon preconceptions. I think as a society, as we get better at talking about death and about quality of life, hopefully these questions will be addressed earlier on and not necessarily at the point at which patients are critically unwell. Now, alongside that second point is whether the critical care treatments will achieve patients' goals for a good life. Now, I take those two I attack those two as synonymous questions when talking to the patient, but they are slightly different. You do have to look at what their goals are, but be mindful of the fact that patients' goals after intensive care do change, and not necessarily for the worse. Their whole perspective changes. They've just had a near-death experience by the very definition of them coming to intensive care. And then the really important thing that I think people often forget about is discussing the non-critical care treatments that are available to them. Sometimes as a critical care physician, when you go and speak to both the patient and the family and talk about limitations of care, they misconstrue this as, oh, we're not going to treat the patient. But in some ways, we can actually give even better treatment to patients outside of the critical care, where we can provide patients with a lot more dignity, calmness, the ability to sleep, a quieter environment, one where we're not as invasive with our monitoring and our assessments of the patients twice, 3 times, even 4 times a day. And focusing on comfort can sometimes make patients that much more comfortable and able to manage their disease process. And if they get better, fantastic. And if not, at least they've had a good quality of death, which I think is something that we definitely forget about. And certainly there are patients we admit to intensive care with full knowledge that they're going to die, and rather than giving them appropriate palliative management, we end up treating them maybe slightly longer than we necessarily should have done or would have done on the wards. I think these numbers are really worth knowing about, because I think they really give you an idea of what intensive care is capable of, and also how we can manage these patients in a more appropriate way. Now, this is not COVID-19 specific, but just looking at patients that all-cause pneumonia. Now, in these patients, what I want you to see is the massive difference in death rates. This is just for patients who are coming into hospital. Look at the 16 to 49 age group. There's a wide age group. We're talking about 10 to 14%, so very low. Then you compare that to patients over the age of 80. You see almost half of patients who come into hospital are dying of their pneumonia over 80 years of age. And about a third of those die, about a third of people who come to critical care die. So you do need to explain to people that even though you're bringing that 80 plus year old into intensive care, there's a 1 in 3 chance or more that they will die despite everything that you do. And that's no better really for the 70 to 79 age group. And it's a quarter of people over the age of 60. So you can see how massively this is increasing the rate of death, and how, especially here, they're not that dissimilar, especially when you bear in mind the fact that a lot of these patients may not be eligible for intensive care because of their severe comorbidities. So we can't give people false hope. People sometimes assume coming to intensive care means that they're going to survive it. And the reality is a third of people over the age of 70 are not going to survive intensive care. And this is for pneumonias. So that expectation setting is really important, not just for the patient, but also for the medical teams that are referring these patients. And then this becomes even more significant when you start thinking about patients with cardiovascular comorbidities. Now, again, what I want you to focus on is critical care mortality, with cardiovascular comorbidities, comparing it with and without. And if you look at here, at the above 70 group, we're talking about 40% compared to about 30%, 30-35% in the people without cardiovascular comorbidities. So if they've had ischemic heart disease, they've got peripheral vascular disease, if they've got symptoms that class them as having heart failure, then these patients do badly. And it is worth talking to them about the fact that there's a 2 in 5 chance, essentially, that the patient will die in intensive care if they've got cardiovascular comorbidities. And again, being really open and honest, and even showing them these tables is helpful, because it helps to set their expectations. Because otherwise, when you come to these patients and their families and say this patient's not for intensive care, they read that as, oh, they could have survived if they've gone to intensive care, but if they didn't go to intensive care, then they're not going to survive. And that's not necessarily the case. And by showing them these values and then telling them and talking them through what intensive care entails, putting lines in, taking blood tests, putting tubes in, long periods of time on intensive care, the critical care neuromyopathies that they develop after critical care, the weakness, the dependence that they potentially have after intensive care, the decrease in their physiological reserve afterwards, they will not come out of intensive care as strong as they went in. All of those things are really important to be open and honest about. And then for all of that risk, you're still running the chance, about 40% chance of death if you've got cardiovascular comorbidities. And the same sort of thing with respiratory comorbidities as well. There's about a 40% chance of death if you've got respiratory problems. And so that's why working out that physiological basis over and above what their frailty index is worth doing, because then you can have a more bespoke conversation with the family about the risks of death. And this is not even thinking about the fact that the COVID-19 group of patients seem to have a very strange course, and we haven't quite worked out what their morbidity and mortality truly are, both in the short term and the long term. Now, once you've done the frailty index, it's really important for every single patient to think about 4 aspects. And I'd suggest every patient, we talk about these things, although, for example, in a 20-year-old who's completely fit and healthy, who runs marathons, for example, who then comes in with critical illness, you may know the answers to these questions already, and it's just a formality, but I think it should be a matter of course that we discuss each and every one of these. So do not attempt resuscitation. I think this is universally done quite poorly, especially by non-intensivists, because firstly, a lot of patients and their families equate do not attempt resuscitation as the same as do not treat, and it is not. The simple phrase that I use for patients, for people, is we are doing our absolute best. We're doing absolutely all the treatments that are needed for the disease that the patient has. Now, if despite the maximum treatment, the patient actually has a cardiac arrest, i.e. they die, what that's saying is that despite the best treatment, they're deteriorating to the point of death. So even if we manage to restart the heart, that same disease process is still going on. So there's a chance that if we restart the heart, that they might arrest again and again. So if it's not something acutely reversible and quickly reversible, then resuscitating them may not help. Also, with every time you resuscitate someone, every time the heart stops, by the very nature of it, by the very nature of dying, what happens is that your level of function drops. So even if we do bring back your loved one, or yourself if you're the patient, we will not be able to bring you back to the level of function that you have now. And by starting to open up those conversations, discussing things in those terms, people start to realise that it's not that we're not wanting to treat people, but it's about giving people dignity of death and making sure that they have the appropriate level of function that they would deem as appropriate for them. Now, for some people, they might say, hey, I'm more than happy to be in a nursing home, to be completely dependent. The thing that I want more than anything else is to live so that I can see my grandchildren grow up. And that is absolutely fine. And we make no value judgment on that. But I think it's important to start having those conversations. But if, however, we feel that even with resuscitation, you're not going to survive, then we need to talk a little bit about that, because then we're not offering them the ability to live in a nursing home and see their grandchildren. All we're offering them is to give them CPR and to give up after half an hour, 2 hours, and have not given them any prolongation in their life. Or even if we did, they'd be in a permanent vegetative state due to prolonged anoxia. Treatment limits are difficult, and I think that should be discussed with the family, with the patient, and a senior intensive care clinician or senior medical or surgical clinician. I think throughout all of this, the last 2 points, these 2 here, is the number one thing to focus on, and that is giving patients dignity during their disease. Some people do not find it dignified to be on a ventilator, to have a tube down them, to have multiple lines in them. And we also need to make sure we give people dignity of death. If we know that patients are going to die, there is being able to be in a side room with without being poked and prodded, having all the investigations, having your family around you, I think is really important. And quality of life. It's a really difficult equation to have, because the honest truth is we can't look at a crystal ball and predict it. We can only go by our experience, and that's why the morbidity, mortality data that ICNARC and others provide is really important to get a handle on. But you should be open and honest with your patients and their family at all times and say, look, you don't know. but this is the likely outcome based on experience, based on research. Now, the escalation policy is that if patients are deteriorating and they're for critical care, then the critical care team need to come and they need to consider intubation. And that begs the question, who do you intubate? Now, the NICE guidance don't talk about this, and my honest answer is I have no idea. The disease process is something that we're just starting to learn about, and if you're interested, please go and have a look at my videos on why patients potentially could be hypoxic. This understanding is always changing, but the L and the H phenotypes seem to be different disease entities and should be treated differently. What saturation should be using, if saturations is a useful aid at all. Should we be looking at work of breathing as transpulmonary pressures an important thing, and are we potentially increasing alveolar damage to patients by not intubating them early? Honestly, don't know. There seems to be a lot of work coming out that's seeming to suggest that high flow oxygen, CPAP, might be helpful in these patients and preventing intubation early on. Again, if these patients develop things like the biphasic response, if they move into an H phenotype, then probably intubation is a better thing. But honestly, I have no idea. I think as time goes on, we'll get a better idea of what it is. At this point in time, still early intubation seems to be intuitively better, but that's changing in terms of our understanding of the disease. So really, I wish I could give you an answer, but I really can't. It's worth just considering extracorporeal membrane oxygenation. Now, there's the NHS England provided a document, and there are various other documents available. The honest truth is, we don't really know with COVID-19 who responds to ECMO, who doesn't respond to ECMO. Should we be using ECMO at all? We have no idea. There have certainly been a number of patients who have survived ECMO who otherwise would not have survived their intensive care stay. So certainly it saves some lives. So I'm by no means discouraging it. I think it definitely has a place in COVID. However, what that place is still needs to be worked out, and we're way too early in this pandemic to know exactly what the answer is. I thought it'd be useful to put this slide up because this gives the inclusion criteria for ECMO and how you'd start to assess a patient whether they should be for ECMO or not. And I just want to introduce you to the lung injury score, the Murray score. And I think it's quite a useful thing just to have in the back of your mind, because actually this may not be that appropriate for patients with COVID. Because one of the things that we score people on is their chest radiographs. Now, you and I have probably seen quite a few patients now with chest x-rays that look relatively normal, that don't show that typical consolidation we see in ARDS patients, and however have severe respiratory failure, and we're finding difficult to oxygenate. Similarly, the PEEP. Now, we've definitely started seeing patients that are PEEP responsive, especially in the H phenotype, but when you're in the L phenotype, these patients respond better to lower PEEPs, and this is because these patients are more problematic with their VQ mismatch. So again, this score that we use, the lung injury score, probably may not be the best thing for patients with COVID. And there is a question, should we be putting these patients on ECMO during their L phenotype, where they may not have as much consolidative change, but they do have difficulty with oxygenation? And we know for certain that these patients, their compliance is actually brilliant. They've got a low elastance. It's in the L phenotype. So you can see how this scoring system may not be that useful in patients, especially with the L phenotype of COVID-19, who are difficult to ventilate and oxygenate. So the reason I put this up is just don't purely go by what the ECMO indications are. Have an early conversation with the Severe Respiratory Failure Centre if you're worried about the patient, because they will use their clinical judgment, not necessarily just purely looking at the scores from the lung injury score, the Murray score. Contraindications wise, I think these are interesting. We talk about patients with high peak pressures above 30 and high FiO2s for more than 7 days. I think this is a relative contraindication, but I think the 7 days is important, and the reason that came about was really because of the argument that after 7 days of ARDS, through the ventilation that we've done and through the disease process, these patients may well start to develop fibrotic irreversible lung disease. And also, if they've not responded to 7 days of appropriate treatment, is this lung pathology actually reversible? Again, with COVID-19, this is going to be difficult because some of these patients, especially the H phenotype, can get hepatization of lung, very tough to ventilate, but we have seen people get better from it. So whether this peak pressure is actually a contraindication or an indication that we should be going on to ECMO if they are starting to require higher pressures, again, difficult to say. Now, the other thing is all of these patients need to be heparinized. Well, I put that in proviso. We do start people on ECMO without heparinization, but for the most part, these patients need some degree of anticoagulation to prevent clotting of the membrane oxygenator. Now, the reality is with COVID-19, there's more and more evidence coming out that it might be a hypercoagulable state, so actually this is probably not a problem, but it's worth thinking about. Now, the question of whether ECMO is the right treatment, I don't think you can really answer, and I don't think we'll be able to answer for a while yet. We need way more experience. The reason I bring it up is that there was a commentary written in the Lancet that was talking about ECMO in COVID-19 and postulating that maybe it could cause more harm than good. The honest truth is I don't think we know, and we can't answer this question yet. We need way more experience. I think ECMO certainly has a place, but that's anecdotally. We need the evidence to really be there to say one way or the other. But the reason for this editorial was based on the paper published in Lancet Respiratory. It was the Chinese Wuhan data that showed that 5 people went on to ECMO, of which 4 people died. Now, you have to bear in mind that the system was inundated at this point. They were dealing with a condition that they didn't really know what it was and how to best manage them. So we may be talking about a group of patients who would have died anyway. But they looked at things like IL-6 levels and found that IL-6 levels are much higher in those patients who are on ECMO than those who aren't. Now, one could argue that could be because the patient is more critically unwell. However, they did also show, and it has been shown in various other papers, that you can get decreases in the white cell lineages when on ECMO, partly through consumption in the circuit, through the membrane oxygenator, and just as a response to being on ECMO. And that arguably that might be preventing the fighting of the virus itself. The honest answer is, we have no idea. It's worth thinking about, and using ECMO as a panacea for patients who are deteriorating may not be the appropriate thing, but we need a lot more research to know exactly what the right treatment is and when to refer people to ECMO, because certainly the traditional framework we have for ECMO is probably not the right one for this particular disease process. So I'd leave you with this nice summary that NICE have done. And essentially it goes through the flowchart of how to manage these patients, essentially at the point of coming to critical care. The key thing is to do this frailty index. Now here they've talked about it being under the age of 65, but other papers looking at frailty indexes talk about lower age groups. But essentially, look at the patient, do a frailty score. If the frailty score is 5 or more, then you need to talk to both the patient and the family and the treating teams about whether the patient is appropriate for intensive care. Give them the treatment that you would outside of critical care as you would, And if they deteriorate, you refer to critical care, mindful of the fact that they've got a frailty score of more than 5, and having those discussions continuously about what the patient wants, what the family want, and the chances of survival. If they don't want critical care, you still do the same treatments. So the worry that people have about not getting appropriate treatment if they don't come to intensive care, it's not true. It's just the organ support that we don't do. And if the patient improves, fantastic. If they don't, then this is the major difference. We start them on end-of-life care. What is end-of-life care? It is very simply focusing on the comfort of the patient. We can still continue treatments if we need to, or stop them and stop poking them, stop bothering them with observations, giving them some medications just to relax them, get them out of pain, and to allow them to pass away peacefully. If they are less frail, a frailty score of less than 5, and I would emphasize the fact that they want critical care treatment, always have the discussion about whether they want it or not. It's quite simple. It's the usual thing of initial management, and then if they deteriorate, refer to critical care. But the focus of this document was really just to try and get people to do these frailty assessments, to assess whether patients are appropriate for intensive care, and to have those conversations early on. And especially in disease process of COVID, we find that patients are fairly lucid at the start of it, and so it's the perfect time to discuss these things, and therefore not give treatments that the patient wouldn't have wanted, and give them a situation of having a quality of life that is not something that was acceptable to them. I hope you found this useful. I'll be providing a lot more videos on COVID-19 in the coming future, and I'll be trying to do focused reviews of specific interesting papers, just so that we can keep abreast of the evidence as we're going along. If you want to be updated of those, subscribe to the channel and hit the bell notification. You'll get an alert whenever one of those videos comes up.